for this panel discussion, and it comes right after a very excellent presentation and discussion about the situation of diabetes prevention and control and in the Caribbean. The objective is for us to share contributions of the diabetes associations in diabetes and prevention and control in the region, as well as to discuss some challenges and lessons that have been learned from the civil society organizations' involvement in the prevention and control of diabetes. We have, expected outcomes of this meeting. One of the expected outcomes is the strengthening of regional network of diabetes associations and identification of opportunities for enhanced prevention and control of diabetes, working together in collaboration with other NCD NGOs. So although our focus is on diabetes this morning, we also put it in the context of the prevention and control of other NCDs. We have a 4-member panel here, and each member will present for 5 minutes. And having, again, gone over time, one of the lessons we are learning is that we want to work a little bit harder to stay within the allocated time. So I would invite our members of the panel to make every effort to do so. And we will start off with Dr. Diane Brathwaite, who is the Medical Director of the Diabetes Foundation of Barbados. Please help me to welcome Dr. Brathwaite.
Thank you very much for that welcome. I'll do my best to condense 10 minutes into 5 minutes. So basically, I'm the clinical director of the Diabetes Foundation in Barbados. This is an organization which was founded in 2001 by Dr. Oscar Jordan, Simone McConney, podiatrist, and Dr. Carla Goddard as well. In 2014, the foundation opted to take an approach towards diabetes care, which was novel to Barbados. And this is the establishment of a multidisciplinary, interdisciplinary care approach towards diabetes and the development of the center. There's been a partnership between the Diabetes Foundation, the Ministry of Health, other invested bodies would be the Memorial Holder Trust in Barbados, which has invested heavily in us, and the government elections time, which helped to support the development of this. So what happens right now at this point in time is that we see both private clients and public clients. We receive patients who are referred from the polyclinics or the healthcare centers in Barbados, and they are actually entitled to a package of care. I'll just get the pointer to change. Yeah, how do I do it? Okay. Okay, and there's a very strong focus on self-management education, a patient-centric approach, where we more focus on, so the patient being really the center of the approach and the key decision maker once they have the information. So we are there really to inform the client and to encourage sensible decision making towards their care. So what are we focused on? We focus on prevention, control, professional education, partnerships, and local research. Okay, so in Barbados, what's our reality and our challenge? We've already heard all of this yesterday. We've heard some of this morning as well. We have extremely high rates of diabetes and prediabetes in Barbados, okay? We don't have established screening programs which are implemented and mandated through policy in Barbados. Also, if we look at self-management programs, there isn't a clear standardization across polyclinics and across healthcare services. Nutrition understanding is exceedingly poor, and I was very glad to hear yesterday that there are moves to get information about nutrition and chronic diseases on health on the syllabuses within schools. So that's where it needs to start. By the time we get our patients, they've had 40 years of misunderstanding and poorly ingrained habits, and it takes longer than to undo that kind of thing. There are a lot of psychosocial and cognitive barriers as well that we see in our clients, and as part of our what we do there is as soon as somebody comes through the door, yes, we do an assessment on them, but they are also screened from a psychosocial perspective. We have depression screening tools. We also do diabetes distress screening tools as well. So as a follow-up to the last lecture, it's important to recognize actually that diabetes distress is a recognized entity on its own. We argue that there may be a barrier into depression, but the two, it's difficult to unravel the two, but you do have to screen for it because diabetes distress can be managed managed. And we do find people becoming less distressed or depressed after you're able to address some of these distress issues. There is obviously an obesity epidemic, we know this. In our population, we can actually see about 75% of the patients that we see are actually overweight and obese, and that's much higher than local standards. Lots of cultural myths and perceptions, high-risk pediatric population. In males, poor healthcare seeking practices and high complication rates. A lot of our younger males, they represent a very small part of our clientele. Males, probably about 12% of the people we see. Our last 6-month audit was up to 25%, which was nice and reassuring. In our younger people, what we are seeing in males is a very big element of marijuana use. So not even so much the nicotine, but the marijuana use and behavioral issues, which are very big barriers towards their care. So this is just a little diagram just showing how we look at the other things. So the things that are important to us are the challenges: inadequate self-management, health-seeking practices, cultural, psychosocial, and cognitive barriers. Okay, so basically, we have aimed to look at prevention, promoting prevention through partnerships, really. So we have associations with the local Diabetes Association, which is strongly community-based, other partnerships through the Family Planning, Heart and Stroke Foundation, now the Healthy Caribbean Coalition. We also have started to develop partnerships with the Barbados Cricket Association, football associations, big supermarket chains, Massey, schools, etc. But the whole idea of partnership is you want to partner, but you also want to give people responsibilities as well. It's not possible for any one entity to do everything. So it's about empowering everybody within the community to take on these messages and roles as well. Looking at high-risk pediatric populations, we've done some work with the pediatricians from the hospital, where they've actually been referring a few of these children to us with prediabetes, metabolic syndrome, dyslipidemia, etc. And we've been taking them through some intensive programs in nutrition and kind of self-management, but we don't do it just obviously with the child. It has to happen as a family-based approach. Although we know the value of group and peer education, sometimes we find that a bit challenging in our population based on everybody's personal agendas. But however, what we found is that a family-based approach towards education and self-management has been quite effective. There's also partnerships with the media, intense management of high-risk adult patients. So if they have a very strong family history, metabolic syndrome, or pre-diabetes, we do actually manage them literally as if they are already diabetic. And then education of physicians and auxiliary care providers. So another important point there is that the auxiliary care providers are equally important stakeholders in diabetes management as well. And we want them to practice at their highest capacity and level. So it's something that needs to spread throughout the whole nation, really. So at the center, services, these are the services that are included. So you can see the physician consultations, diabetes specialist nurses, medical nutrition therapy, physiotherapy consultations for patients who cannot exercise for whatever reason, and individualized exercise. We have a diabetes foot clinic, which has very good links with the vascular team, surgeons, etc. Support groups, as I said, have not been as successful as we wanted them to be, but we have found that family type education and groups tends to work better for us, or approaches. Diabetes self-management education, mental health and cognitive function assessment and follow-up. This is something that is so important. You can't break through barriers for cure when you cannot break through somebody's psychological problems or their mental issues. However, we don't have enough funding to support this as well as we'd like to have it. Then we have retinal screening. This is a very simplified chart here. I could have showed you lots of bits of data, but it's something that I like. It's just a diagram showing what we achieved in 23 patients over a 6-month period. So in the polyclinic, we only have a 6-month program. So in the blue line, you can see where the starting A1Cs were, and the red lines are where the ending A1Cs are. A lot is possible. And however, that possibility does not lie in our skill only. It lies in self-management, education, and patient empowerment. So that person is now ready to take on that challenge. I have a few points, however, and the question is what is the way forward? Because it's wonderful to achieve this. It's wonderful to drop somebody's A1C by 4% or 5%, whatever is the case. But the question is what happens to them over the long term? So we do have the need for funding to continue to do some kind of long-term kind of studies to see what happens to these patients, what models of follow-up and care are actually going to help them to stay on these targets and continue to improve actually. Because we can be happy with our 7.5, 6s and 8%, but these are not, these are not targets. Targets for our patients are individualized, but we still want to be reaching international kind of targets and gold standards. So in the way forward, it has to be longitudinal follow-up. It has to be partnership with other community-based and primary healthcare interventions and programs so that patients can have the supports that they need on the outside to continue to achieve this. It has to be strengthening the knowledge base and the capacity of auxiliary care providers and other invested citizens. For example, we need to be looking at bodies like simple things, beauticians. The majority of our patients will go to get their pedicure, but they may not necessarily come to a podiatrist. So even talking to things like beauticians, we have found that they are actually faced with this burden of what do they do when they have diabetic patients asking for advice, exercise people, community-based types of things. So with that said, I could go on and on. There's a lot to say, but just thank you very much. And once again, the message is really in empowering patients and self-management education at an early stage.
Thank you very much, Dr. Brathwaite. And we will move right along and invite Mrs. Lurline, the president of the Diabetes Association of Jamaica.
Thank you, Juanita. So Professor Morris is our president and the chair. So you can go ahead. Right, so the Diabetes Association of Jamaica is an NGO that started in 1976, so that makes us about 42 years in operation. We work with government and private sector. So we provide primary and second level care for diabetics, and we do primary prevention, such as medicals, done through medical screenings and diabetes education, in communities. Prof. Morrison spoke about this this morning. So we also have a diabetes medical center which provides secondary and tertiary care treatment. And this comprehensive approach of the private and the public coming together, started in 1998. So we have 4 branches island-wide where we, have smaller scale operations, meeting the needs of those communities in diabetes care. And we do extensive outreach activities in communities such as screening and medical checks and diabetes education. Next. So the mission of the Diabetes Association of Jamaica is to offer services and support for all activities which will lead to a better quality of life for those affected by diabetes or at risk of developing diabetes. The vision of the organization is to empower individuals and families, and let us underline the word families. And I pay attention to Professor's 100% depression in diabetics. So we can't rely on the diabetic themselves to care for themselves. So we have to empower families and caregivers to take some of the responsibility, because guess what? When the complications happen, it is the family who carries the burden. All right, so we have to include them. And I should just say that we do kidney dialysis at Diabetes Association, and oftentimes the family members will come and say, had we known that this could have caused kidney failure, they would have paid more attention. So we have to listen and respond accordingly. So to ensure a more widespread practice for healthy lifestyles and to provide quality health care at affordable costs. So the services offered by Diabetes Association of Jamaica, diabetes education, which is number 1, because unless the population understands, not just educating, but can understand, internalize, and implement those measures towards their management, we will not get the management or get the control of diabetes we need. So that has to be more focused on for our patients. Medical consultation and referral clinic, we do retinal screening, and I should just pause here that yes, a number of patients in the diabetic population is only 10%. The Ministry of Health says only 10% of the diabetic population who gets retinal screening done. right? So we have started this program and we screen 1,000 patients. 57% of the diabetic screened had some form of a diabetic complication, diabetic retinopathy, cataract, glaucoma. Interestingly, 20% of the kids that we screen, and of course, we are saying kids because our Life for a Child program cuts off at age 25, 20% had some form of eye complication. Kids as young as 14 and 17 had diabetic retinopathy. It's frightening. We are seeing teenagers with kidney failure alongside the diabetic retinopathy. So we don't want to keep hearing the problems. We have to now do what? Find the solutions. Because I think we've been hearing this, Prof. You said 40 years. I'm kind of on the beat for 30 years. So we have to find the solutions to improve the quality of lives of persons. When you look at youngsters, I mean, come on, the diabetic youngsters cannot be a lost generation. We have to do something for them. So it was frightening when these results came about, and then with the expensive cost of care, right? So to do the LASA is about 85,000 Jamaican dollars. What is that now? About 800 and about how much K? 850 Jamaican dollars or something, right? So it's expensive, and so it's not accessible. So the care is not even there. So we really have to move towards getting, parallel programs. So as we screen, we treat. We need to improve, because when a child has kidney failure and diabetic retinopathy, what do you think happened to the family? The whole family is in distress. It's not just that person. So you have to look at extension and how it impacts on productivity. And there's so many other costs associated with this as downtime. So we really need to make a move to prevent these things from happening. And there is increased risk of the kids with diabetes. They're younger and younger persons that are developing diabetes, as you can see, from the global data. So for our best practices, we have the lay diabetes education program, where we deal with the modifiable risk, such as unhealthy eating, physical activity, the dangers of tobacco use. And then you have the intermediary risk, which deals with elevated blood sugars and blood pressure, elevated cholesterol, and of course, obesity. We know that it's a predisposing factor, so we really have to address it. So what we have done, we work very close with the Ministry of Health. So the standard of care we're looking at is one from the Ministry of Health, but we put it up on our board. We give it to our patients via what you call the chronic care passport, right? We should congratulate the ministry for having this little booklet that carries the same information. Guess what? It's not for me to keep in my office. It doesn't belong, it belongs there, but it's not for only me alone to see it. Every single person ought to have the information, so they take home, share it with their family members, or we educate them on what this passport is saying, what these standards are, and how the person, the patient, is matching up against these numbers. They're from the Ministry of Health. So our achievements, the opportunities to meet our mandate of raising awareness of diabetes, official clinical care, offering screening and education across the island, and of course, retinal screening. Retinal screening, diabetics achievement, lay diabetes education program, island-wide screening, and the Life for a Child program. I could just expand on that. This is a program that is run by the International Diabetes Federation, where their insulin, test strips, blood glucose monitor, lancet, syringes is made available free of cost. So we have 350 children registered in this program, where we work through 10 hospital systems in the Ministry of Health system. If you notice, we work very closely with the Ministry of Health, because they are the guide of the policies of ministry in the country. So we can't operate on a tangent. We have to be speaking the same language, right? So we deliver the supplies quarterly to the centers, and the kids would go in and access. So the key points, the NCDs burden on families, community, and country. Ministry of Health says about $422 million US, and increase public education awareness on NCDs in schools and communities. Recommendation, educate the population on good nutrition choices. I heard Prof spoke about glycemic index. You know, looking at a complete plate, not just an aspect of the plate, but the full consumption. We need that to be readily available. Again, this information doesn't belong in our offices. They need to be on everybody's household, in everybody's household, and it should be known by every member of the family. A diabetic doesn't need a separate plate, you know, because the entire family should be eating the same way. So let us stop the segregation of diabetic and a diabetic diet. So we all eat in small portions. So you make, no, I didn't finish. So more ongoing public education, more health screenings and referral and follow-ups, better access to medication through different health facilities, improve presence in schools and communities. So we need to do more activities in our schools and in our communities. Advocacy on healthy eating habits and improving physical activities. We cannot overemphasize that bottom line, healthy eating habits and increase in physical activities. Next. So this is the contact for the Diabetes Association of Jamaica. And I thank you very much.
Thank you very much, Lurline. We now have Dr. Bernice Dyer-Regis, who is Education Officer of the Diabetes Association of Trinidad and Tobago. Okay. Just the arrows to that. Press that. The arrows.
Good morning, everyone. The GDP of Trinidad and Tobago does not allow us to qualify for some of the grants that the other islands receive. And so we function on a minimum budget, and most of it comes from government subvention, which does not always materialize. For example, between November and February, we receive no subventions. So we maintain sort of low-level, manageable activities. And we see our role in terms of screening and counseling and referring, also education for the prevention and management of diabetes, research, which is a new area for us, and advocacy. One of the areas where we really provide a unique service is in the area of a residential camp for children who have been recently diagnosed with diabetes. Although we find that there are some children who keep coming back year after year because they enjoy the experience so much. But we know that being diagnosed with diabetes can really be a traumatic experience for a child. And for that, they would require a lot of support. So the camp requires a lot of resources, a massive amount of resources in terms of having nurses providing service around the clock. We have to have, a doctor there, cooks, dietitians, facilitators, diabetes educators, and we find that the older children, they function as peer counselors for the newer ones. Then in 2016, we were able to extend an invitation to other Caribbean countries, and we saw that some of them accepted the invitation and participated in the camp, the residential camp for the children. However, in 2017, due to financial constraints, we had to reduce it to just a 2-day workshop for parents and children. But we saw Tobago being able to have their own residential camp for their children over there. And that's a picture of our Minister of Health. The Ministers of Health always participate in the camp, at least for the opening session. And that's a picture there too. You would see our First Lady, our then First Lady, Miss Rima Kamona, who is the patron of the association there. Yeah, we also do screening, and it's provided by our volunteers, our members, Diabetes Association members, and we were able to do what we could have done in 2017, which totaled As you can see, 2,915 hours provided by our volunteers. And we screen for diabetes, hypertension, and to a lesser extent, cholesterol. Right, so the area in which we have recently ventured is that of research. And we did this in collaboration with the MED Health Promotion Program at the University of the West Indies. It's a program that I coordinate, and I encourage the students there to conduct diabetes-related research. And so they looked at the one group looked at the school experiences of children living with diabetes. And it was almost like a horror story when, the findings came in. So these were qualitative research where the students were able to express the kinds of experiences that they have in the schools. And the teachers didn't recognize the difference between high blood sugar and low blood sugar. And so many times they thought the children were being lazy. The children wanted an excuse to go outside. They wanted to put their heads down on the desk because they wanted to get away from work. And so the children were punished. Children who wanted to monitor their glucose levels weren't able to do so in a sanitary place. Many times they had to go in the very unsanitary, how school bathrooms can be. And so that is where they went. They spent a lot of time, they said, putting their heads down on the desk, going to the sick bay, just missing learning opportunities. But I think the worst part of all is some of them were prevented from taking part in sporting activities, from going on field trips, getting involved in extracurricular activities. There was also big issues with the meals. There was one child who said that his mother would come to the school sometimes to see that he's eating on a lunchtime because, like the teachers, he said, don't take him on. But we have to understand too that the teachers don't understand what's happening. They don't understand the condition. And worst of all, the parents many times do not inform the principal about the child's condition. And so we realized that we needed to take up our role of advocacy as an association. And so we prepared some policy guidelines for the school-based management of diabetes. Nothing that we pulled out of a hat, but we looked at what existed internationally and we kind of adapted that to suit our situation, looked at what is feasible in our situation. And we came up on some policy guidelines for the management, for the school-based management of diabetes, which we submitted to the Ministry of Health for inclusion in the school health policy that is currently being revised. And you would see some of the areas there that are highlighted in the policy in terms of even with writing examinations that children should be given reasonable accommodations. Those who are living with diabetes be given reasonable accommodations in terms of writing examination, and that parents should not be mandated to accompany children on field trips because they are diabetic. And parents do have a responsibility to inform the schools and to provide the emergency supplies. So all those things were well documented in the policy in terms of the role of the school nurse. We don't have school nurses in Trinidad as some of the other islands have, but we have district health visitors. And so we identified the role for the district health visitor to more or less to collaborate with others in managing, coming up with a plan to manage the child while at school. Right, the other research that we have engaged in and that we are currently engaged in is the use of complementary and alternative medicine among persons living with diabetes. Now, this is mushrooming. I don't know how it is in the other islands, but in Trinidad and Tobago, it's almost like a fad now. Everybody is into complementary and alternative medicine. Everybody is taking moringa. We don't know how much is the dosage for moringa. We don't know if we are overdosing ourselves with the moringa, how much saffron we should take. We don't know, but we are taking it because we have heard that it is good. And so, well, that is what is happening. And so the clients are also doing that. They are taking leaves. Everybody's telling you about what they are taking, you know, to help manage their diabetes, whether it is a Carili or garlic or whatever. So, yes. So despite a lack of evidence, we realize that it is increasing, the use is increasing, and so we have decided to conduct the research, and it's being conducted among the 17 branches of the association by the students of the university. And when that is complete, we will train the persons from the Diabetes Association to conduct the same study at the chronic disease clinics at the health centers. We expect that the findings that we receive would be able to inform some policy document from the Ministry of Health, at least adhering to the WHO guidelines for complementary and alternative medicine. Right, and the last initiative that we are involved in, it's the DEAPS, what used to be called DEAPS, which was started in 2002, which we have since turned to COMPRE-DEAPS because it's more comprehensive, because we realize that the children do not live at the school, they live in the homes, and that, as we heard yesterday, that it's not only the school cafeteria that offers food for sale, but the itinerant vendors. And so we have incorporated all of these into this education program for standard 3 children, the itinerant vendors, the cafeteria persons, the parents also, because the children, they live at home, and the teachers. Because the teachers, if they can see some benefit in it for them, and that's why we are offering them screening and the education awareness. And also, if they are aware of what is the information that is being shared with the children, that they would be able to support the behavior of the children. And one of the things that we are really focusing on heavily when we do this program is the whole issue of free play. We realize now in the schools, teachers are telling the children, we do not want you to play because we do not want you coming back in sweaty. And so the experiences of free play, those things are being curtailed. So we are providing an advocacy role in these areas as well as education. Thank you.
Thank you very much, Dr. Dyer-Regis. And our last member of the panel, Dr. Chrispin Gomez of the Diabetic Research Institute of the Bahamas will now present.
Hi, good day. I'm a family medicine practitioner, and I'd just like to tell you a few words about the things that we do at the Diabetic Research Institute. I have been there from 2015 as the medical director, and a lot of the things that we have started are new, and some of the things that we are trying to get on target because we want to actually get rid of diabetes within the Bahamas. The Diabetic Research Institute is actually a nonprofit organization that offers free services to inform and educate our population about diabetes to reduce the scourge of this problem. We have actually introduced the 8 weeks course, which is the Diabetic Self-Management Education course that is actually centered around persons with type 2 diabetes in order to educate them. As we have seen, many studies have shown a decrease or an increase in good outcomes with persons who are educated. We have seen improvements in HbA1cs with decreases as much as 6.2% over the 3 months course. We've also seen great increases in weight loss for up to 20 pounds. On average, we have about 5 to 10 pounds per participant over the 3-month course. We have been tracking the progress, and we see them post the course every 3 to 6 months. And now after 3 years, we are now starting to see that about 1 to 2% of the patients are starting to have an increase again in their weight and their HbA1c. So now we're trying to figure out when should we repeat education on them. Our class size is about 30. We have it 3 times a year in January, April, and in September. We have a graduation at the end to actually congratulate them for completing the course. and see what else they can do as they progress. We also have a type 1 kids group, which are for our type 1s, where we offer free literature, education in terms of diabetes and different things they can do to actually help control their diabetes. They meet twice a month, and we have various activities for them. We also meet and discuss with the parents of the type 1s to actually find out what issues they are having with the children. And also a lot of things are new in terms of new medications coming out that they want to know. And now the new thing is about stem cell, and they want to know about stem cell, what is going on, and can it cure diabetes? And we meet with them once a quarter. Sorry. We also have our young adults, which are persons who are past the teenage, who we actually meet with. They actually have a WhatsApp group, and we see them for various complications. Some now may have end-stage renal disease. Some have complications such as nerve damage, which we meet and discuss various issues that may be going on. We have a few have become pregnant, and we see them in terms of managing their diabetes control. They usually meet by private groups, and they also have WhatsApp where they actually meet. And sometimes if they need to see us, they will call us in, and then we'll have individual counseling with them. Apart from that, from the persons who actually graduate from our self-management education course, they actually form support groups that actually meet once a month to actually help each other in terms of offering further counseling and further help as needed. And this is one of our support groups that actually met, and they wanted to have an exercise program and know more about exercise and keeping control of their diabetes. We also offer individual counseling to persons. Here is a health fair that we did when we actually go to persons' work, offer free screening and counseling about diabetes to see how best we can help. We also go to the schools. We do more educational talks instead of screening in the schools to actually educate them about diabetes, what it is. We also have a certified diabetic educator on board who actually teaches about dietary management, foot care, and all issues actually related to diabetes to help prevent this problem. And a lot of the persons who opt not to go into self-management education course can get individual counseling by this means. Last, we actually have a clinical psychologist who actually comes in twice a month to offer help mainly to our type 1 patients and their parents who have problems because of the psychological effect and the social aspects of diabetes on their life, especially if you have children who have diabetes in a family where they are the only one and have brothers and sisters who don't have diabetes. It actually starts to play a toll on them. We also started a new program this year called the Diabetes Prevention Program, actually geared towards persons at higher risk of diabetes. That's persons overweight, obese, family history of diabetes, hypertension. That's actually geared towards teaching them in terms of education about eating healthy, healthier lifestyle. And we also have a fitness coach who comes in, does yoga, aerobics, Zumba, and various other activities for them to actually try and reduce the likelihood of them becoming diabetics in the future. On a biannual basis, we have symposiums that we have to educate the population about different things that can be affected by diabetes. We had a foot symposium by one of our podiatrists, and we offered free screening in terms of foot care and seeing if persons had any problems with their feet. We also had, for the first part of this year, a dental symposium talking about oral health and diabetes and the things to look out for. And we're planning on having a free dental screening to be done at the Institute earlier in the year. For the next symposium, what we have for the second part of the year, we will be discussing renal health and diabetes. Again, just a little look at the statistics and what we have so far. Over the 3 years that I've been here, we've actually, in terms of new clients, we've actually seen almost 100% increase in the amount of new clients that we see per year to about 230. So far for the year, we have had about 52 new type 2 diabetics, about 20 pre-diabetics, and 7 new type 1 diabetics who has actually come into our fold, who we actually help to educate. We believe that diabetes is something that you shouldn't sugarcoat. So we want persons to actually get the facts, come in, because all our services that we offer are free of charge. And these are some of the team members that we have. We have a benefactor who supports the whole organization and does everything through him. Thank you.
Thank you very much. In the interest of time, we will not be able to accommodate questions. However, I would encourage you to, interact with the members of the panel during the coffee break, perhaps over lunch. And I would just like to just mention that we have seen a range of activities being carried out by the various diabetes associations, ranging from providing care and treatment, support groups, outreach, which involves screening, education, public awareness, health promotion. Also, we are seeing that diabetes associations are also undertaking research, and there's education and counseling being provided on an individual and group and family sessions, the role of advocacy, and also recognizing that there is a great need for partnerships, working with the government as well as the private sector and other NGOs. So there are various roles that the diabetes associations across the region have been playing to work along with what is provided in the government services. I'd like to thank the members of the panel and to thank you. Thank you very much.